know, we are in Alberta, so I'm in Calgary, and I have to say the outline of the treatment has been a bit different. We mainly use Cyborg-D, or we were used to use Cyborg-D until RD has been approved. Now for the newly diagnosed but not transplant eligible patient, RD is the first line of therapy. Cyborg-D has been followed as well, but VMP, which in many centers across Canada has been used a lot, it was never our first preference, I guess, for the toxicity the melphalan unfortunately can bring. But I think we need a bit more for this specific population, especially because we don't have the option to offer them the transplant. Yeah, so the ALCYONE study is probably one of the first phase 3 that is specifically focusing on newly diagnosed patients, but elderly. When I mean by elderly, they have almost 200 patients. They are more than 75 years old, and they actually got randomized to receive VMP or as a standard of care, or daratumumab VMP. There was also another 200 group of patients that actually were considered not eligible for transplant for comorbidity, although they had less than 75 years old. What was neat about the study is the fact that first is an elderly population, and we know myeloma, the incidence of myeloma actually increased with time, and we have 35–40% of patients actually that we see in clinic, they are elderly, they are more 75 years old. So I think it's actually capturing what we're seeing in the clinic. Secondly, we know we are always afraid to use immunotherapy in the elderly patient because we are not sure about what to expect in terms of toxicity, and I think we will discuss the result, but I think the first feeling from the data presented is that they're actually safer and can be used without problems. Going more into the details, what they did on this study was to, for 6 cycles, give VMP alone or VMP plus dara, and then look at, of course, they look at response, they look at PFS, they look at MRD data, and of course safety. So one thing was really important to see in a follow-up of 16 months, there was a PFS not reached with the dara VMP versus was 20 months in the VMP arm. Then the response rate were twice higher when daratumumab was added to the picture, and the MRD status, like assessed by NGS at 10 to the 5th, was actually 3 times higher in the daratumumab arm versus VMP. When all these data say basically is that we are really reducing the risk of mortality, death, progression of 50%, which in this population is really important. So it's true the neutropenia infection were a bit higher in the VMP plus daratumumab, but it's not an issue. We're learning actually that every time we have an immunotherapy on board, and specifically daratumumab, we have to be more careful and put the patient on antibiotic prophylaxis. We use Septra, we use even Valtrex to protect from shingles, so herpes zoster. So I think knowing this information will make us more proactive, so be more, especially if we have a patient with neutropenia, we try to not to wait, but act right away with an antibiotic without waiting. But the other thing was interesting is actually the rate of discontinuation was higher in the VMP alone, not in the VMP and dara. So just at the end of the day, is a tolerable treatment. You know, even if I said at the beginning we don't use VMP as much, what make me think that, again, a triple regimen can be actually is an answer for this specific group of patients. I will say probably for us will translate more so on using Cyborg-D plus dara, or when VRD will be approved, hopefully soon, we can actually argue that VRD plus dara in this population will be probably the best treatment.